Let's make the most of the afternoon ahead.
This conference is the teamwork of all the ACPN members. However, without the continuous support of our affiliated partners, the program could not have been possible.
So let us take this opportunity to thank our partners. They are Chamunda Trading House, Snipe Diagnostic, East West Company, Applied Biotech Company, Techno Biomed, and Agape. Thank you so much.
Their unwavering support has been instrumental in making this event possible. Please join us in giving a big round of applause to all our generous sponsors for their invaluable contribution. So moving on, I'd like to call upon our representative from SESMEX, Mr. Season 10, up onto the stage for his talk. He will be sharing insights on the topic beyond routine hematology. Sir, please.
Hey, good afternoon, everyone. I'm happy and honored to be here. It's great to be in the country of Nepal. This is my first time. First and foremost, I would like to thank the organizers as well as our business partners for the opportunity to be here to share with you some of the things that we do beyond routine hematology and the topic of my presentation today. My name is Swijin Tan. I'm Senior Manager for Regional Scientific Affairs in Asia Pacific with SESMEX Asia Pacific. So, title of my presentation today is to address the considerations in infectious, anemic, and oncology-related applications pertaining to your routine hematology results. So, the outline of today's presentation is as follows. We start off by looking at, of course, the principles of what makes your hematology analyzer work. At the same time, beyond looking at those routine parameters, what can we get out more from those results that you are already ordering for each of your patients? And that brings me then to look at the ability to look at effective testing through unique algorithms that we have shown in Europe itself. That's interesting because this helps the lab. This also helps to understand the patient better with a normal, simple blood test. Moving on towards that, I'm hoping to share a little bit more about anemic screening, anemic testing, some of the guidelines that are available, like the KDIGO guidelines, and how that has helped to allow cost-effective testing of the population, of high-risk populations especially, to gain better care. Then that will translate, of course, then to the molecular aspect for confirmatory testing and, of course, then intervention. And before we end today's lecture, I just wanted to share a little bit more about infection and hoping to look more towards dengue management. And I have seen quite a number of Indian speakers today. They will probably be familiar because a lot of those research are coming out from India. So, and then the summary of today's presentation. And I would say the routine blood test is the most common test you get for any cases that comes to the hospital, especially in the emergency, because that's probably the first test where we are able to assess the overall health status. In a number of different patient groups, we looked at the ability to diagnose anemia, possibly infection. A simple thing will be your total white cell count. An elevated total white cell gives you an early indication of a possible fight towards an insult. And of course then, the ability for us to do very quick monitoring, because if you look at how fast the CBC generates the data for you, it's as quick as 1 minute per test. The principle is flow cytometry based. We interrogate cell by cell. At the same time, when we looked at each of the cells, we are able to get the type and the amount of nucleic acid and the cell organelles through your site fluorescence light, the intracellular information through the site scatter light, as well as the cell size information through your forward scatter light. So, with this information, the system is able to separate the cell types all together for you, and hence the reporting of your differentials. And behind the differentials, there are intermediate parameters that I'm hoping to share today that will help probably some of the critical cases, the challenges we see in some of the patients. Hence, if I can just quickly share, the first diagram shows you a scattergram of the WNR channel. It gives you very rudimentary information of your NRBC, your total white cell, your basophil, possibilities of platelet clumps. That's where probably if you're in the lab looking at an instrument, when you looked at the first scattergram, even without a flag from the instrument, we are probably able to then approach the pathology for smear testing itself. So effectively streamlining some of the laboratory processes. And that will link me to the first topic of the CBCO algorithm later. And this is probably the most common scattergram that you will see in any of the blood tests, the WADF scattergram, which gives you your differentials as well as your counts. And going beyond that, I would think this is something I would want everyone to have a little bit more, because going beyond routine CBC, there are actually 96 parameters outside of your routine CBC that are not reported. And of the 96 parameters, if you are able to follow through these parameters, there are those related to infection, those that are related to pediatrics that we can probably correlate better, and those that are related to things that we can improve for laboratory efficiency. And if there is any interest to look at this entire list, please feel free to approach our business partners. We actually have booklets, scientific booklets that are able to share a little bit more information. And of course, if there are any other further information, Sysmex can come in to help you to look at how we can use those parameters with you. The question we want to ask is, what are these parameters? As mentioned, can we make use of them better because they are already there the moment you order the test? So it comes at no additional cost to the patient. It comes at no additional burden to the lab. It's basically the pathologist, the hemapathologist, who needs to be able to make good interpretations out of those parameters and be able to use them in daily practice. And hence why we are hoping that we want to share some of the best practices in Europe, in Asia, to be able to utilize these parameters effectively. And that brings me to the CBCO algorithm. A little bit of background. This was developed in Europe. It's really to help understand how can we deal with difficult samples at the start. But when we looked at, of course, the algorithm itself, there are cases of true pathological conditions that cannot be overlooked. Hence, the algorithm itself builds into consideration of both the laboratory efficiency plus finding true pathological conditions. So the question we see in the lab, the challenges from the specialists is, and we looked at today one parameter only, MCHC being too high. It could probably be a very small number of cases per day in the laboratory. But to be able to troubleshoot that 1% or less than 1% of cases, it takes a couple hours. For example, in a co-agglutination problem, you warm it out in a water bath for an hour before you run it again. And then the question then is that, is it going to be the same? If it is the same, it's going to probably be wasting a lot of time for the lab. So we want to be able to streamline those processes as early as possible, at the same time be able to tell you at the start, how can we then check the sample as quickly as possible to be able to give the patient the result as rapidly as possible. Hence, it really goes from people who are working in the lab to really the decision makers, which are yourself, to be able then to understand, can we increase productivity by employing some of these parameters into improving laboratory efficiency. Then the other spectra will be the clinicians, especially we want to be able to check if the high MCHC is reflective of a true pathological condition. The concept is quite simple on the instrument, which is automated. We run basically an initial CBC order For samples that flagged out above 36.5 grams per deciliter for MCHC, we reflex on the reticular side, and that will give you your optical result. Through the optical result and comparing that with the impedance data, the instrument will be able to make a good check if it is truly pre-analytics or pathological. So in this case, artifact or real. So the process is really automated. It simplifies the high MCHC management. It improves standardization. We have heard the need to have accreditation, the need to ensure that your processes are well documented through good SOPs, either with the CLSI guidelines or with any other standards. And hence the importance of IT, where we are able on instrument or through middleware to be able to provide this process for you. So how does the algorithm really look like? I would encourage you to break them up into branches. So with a high MCHC, we run the red channel. We compare then the optical versus the impedance. And the result from one of the studies earlier in 2016 show us that this could probably be a co-agglutinin issue. And based on the actual laboratory practice, then we will want to look at how can we report this result as early as possible. So with the comparison itself, the instrument will be able to prompt out a possible co-agglutinin, either then through the water bath, or if the red channel, which is already running at 41 degrees Celsius, does provide semi-correction for the sample testing itself. So is that sufficient? There is data coming out from Singapore General Hospital, which we will be presented at the latest ISLH 2024 this year, to show that it is 100%. At least for the red channel, pushing out the optical result shows that they do not need to run that on the water bath anymore. So I think that's useful. Saves you at least 1 hour of your time. The productivity can then be looked at for more difficult samples. For example, the other spectra, the RBC disease. So in the middle, there are, of course, others like interference and of course, overlap with the co-agglutinins. But there is the interest to look at true RBC disease. Are we able to then also flag out true MCHC cases? I will not be doing too much of the math today. So there is a specific algorithm which we measure FRC together with delta He to be able to then calculate a score. The magic cutoff number that we looked at is 0.127 to be able to differentiate between a true case versus that of the other kind of interferences. And that will allow us to split out into quite a number of different conditions like sickle cell, like IDA, together with red HE, and to be able to look at all other aspects, including MCHC less than 36.5. So that complements whatever the lab is already practicing, plus the ability to streamline difficult cases that are above 36.5. So that algorithm is unique because it is a simple process. If you ask very experienced people in the laboratory, they will tell you that this is basically the steps that they follow. So what the instrument does for this group of people is that now we make it automated, we make it streamlined, we make the learning process for new technologies to be shorter. Hence the ability for them to pick up this kind of testing methods as quickly as possible. Hopefully, of course, that process for the technologies, for the specialists, will be quicker. They get to get more experience with difficult samples without having to really scratch their head, pull their hair about what to do with the samples. And of course, then approaching the pathologist for help. But of course, the pathologist is there to be able to right the wrong, get the most difficult samples through to the patient as quickly as possible. And that really brings me to the next topic of anemia. Anemia is a challenge for a lot of different conditions, including pregnancy, including even infection, including dengue, which is the last topic that we will discuss today. And research shows us that red HE is an important clinical parameter, and I hope that you are familiar with RED-HE because it is in the KDIGO guideline for chronic kidney disease. The ability to manage, to detect early anemic conditions in CKD. So it is important because in CKD cases, you want to be able to detect these cases quickly to have, and interventions are quite easy. The key indicator is iron availability. And if you look at scattergram itself, what we are measuring is the ability to see if the iron stores are sufficient. If it is insufficient, there is already an indication that the patient is anemic, and possibilities of essential to look at iron deficiency. So as we looked at KDIGO, the anemia in CKD, there is, it's referencing back to reticulocyte hemoglobin or any of the other equivalent parameters. This is essentially done when you have the reticulocyte channel on the hematology analyzer activated. So any sample with a red channel done on the Sysmex XN will already give you your RED-HE data set. The cutoffs are also presented for different conditions, different patient groups. I'm showing you data from UAE really addressing the issue of diagnosis for iron deficiency in HD patients. And of course, the testing of RED-HE for this group of patients. And if you looked at how this is done, it's really a straightforward and direct measure. Be able to quickly give out the results in less than a minute. The AUROC in this case is more than 0.85. And if you looked at the optimum cutoff, this is to differentiate the IDA cases. This AUROC, we're looking at 0.876 through a study in Thailand. By measuring this, what they have proposed is if you do an initial RED-HE measurement with the cutoff of 30 picograms, we are able to do early identification of or rule out of IDA cases. Or if they are less, then we check EGFR. And if it is no, what happens here is we want to check if thalassaemic conditions are interfering. And if it is no, then we want to go back to your routine, which is ferritin. And once confirmation can be done, then from here, the ability for you to see that if I'm able to already identify the right groups at the early start, it saves time, it saves cost for the patient. That's where we see that exploiting some of the parameters that are not reported but clinically relevant can be useful. And of course, comparison with other classical biomarkers, I would say that RED-HE is really an early marker for disease testing. And it probably can be as quicker, if not, the dynamic change is much faster when we measure that on your CBC. Okay, the last part is on infection. Infection is really a topic that is challenging in Asia because there are just too many types of insults. It could be just trauma, it could be dengue, and previously we just went through COVID-19. Hence, today we talk about dengue because I would say it's not just in Nepal, it's a problem in Asia. Even in Singapore, this year dengue numbers are higher than that of last year. Dengue deaths are increasing, DHF cases are increasing. And I'm showing you data that I got when we looked at Nepal. If you looked at just 2014 to 2019, you can see that the red regions have increased significantly, meaning that the number of cases are increasing exponentially. And this is from the paper that was published in 2021. If you looked at the number of deaths, it remains relatively low, which is good. But if you looked at the number of incidents of the confirmed dengue cases, we are seeing a very big exponential jump. This is similar trends for most of Southeast Asia as well. So that is a cause of concern because with increasing numbers, it will get more difficult for the healthcare institutions to manage that number of people, and we have seen in COVID-19, it overwhelms the entire healthcare system. That is critical. And I'm hoping to share some of the data available for testing on hematology parameters. The data from here is from an older instrument on the XE, where we have seen that parameters like the atypical lymphocyte, high fluorescence lymphocyte count, IG, and IPF on this instrument have shown to be useful to differentiate between different types of infection or causes of febrile illnesses. And then we will deal off with the thrombocytopenic cases in later slides as well. So, IPF, focusing on just one of them today, immature platelet fraction. The ability for us to look at it as a diagnostic tool for various hematological disorders. Today we looked at dengue. The ability for us to monitor platelet recovery. That's data coming out from India, Hinduja Hospital. As a prognostic indicator in various hematological disorders, including MDS, monitoring platelet function, and of course, the last part, let's look at just dengue clinical management. So we looked at the ability to differentiate the type of infection. And in this paper, what is shown is the type of causes of febrile conditions, as well as the different phases of dengue. That includes the critical phase, the early recovery phase, and the convalescence phase. And you can see that the patterns itself with IPF is significantly different from that of the rest. And in this data set, what is shown is that just with a single parameter for IPF, in dengue cases, we have seen the highest median levels. It's similar for all other conditions like leptospirosis, acute dengue. We have seen similar patterns as well. So as you can see, dengue at its different stages will have different levels itself. And in this case, when we look at data from India, where they generated the reference intervals, an interesting aspect of looking at IPF is that we are able to see the trend for platelet and IPF to be rather similar, or I'll say in contrast, but IPF being earlier than that of your routine platelet monitoring. So before you see a platelet rise, we are already seeing that the IPF values are at its peak. And in these cases, 84.3% actually recover within 24 hours if we are able to identify that peak. And the rest of them actually recovers within the 24 to 48 period, 100%. So this data is useful as we looked at recovery after the peak, recovery after the rising trend, and recovery after the falling trend. So in this stat, we are able to identify 100% of cases that actually recovered within the next 48 hours. So 2 days earlier than that of your platelet measurement. So the highlights are that IPF is a precursor, really addressing platelet formation, precedes platelet recovery by up to 3 days. That's data that we have seen in Malaysia. IPF is higher in patients with severe dengue. It's closer to that of the normal other febrile conditions. But in severe dengue, you will see IPF going up very high within the first 3 to 5 days, especially when platelet levels are very low. That's where we see the value of also monitoring in the dengue cases. So IPF could also be an early indicator of recovery, as you have seen in the earlier slide. That data set has been also tested in Malaysia, Thailand, where we have seen similar trends as well. So further studies, of course, are really needed as we looked at expanding the use of IPF together with other parameters like IG, which has an indication for severity as well. So this is my last few slides. I will say that the research in dengue is interesting. The research to use hematological parameter is also quite active. I have data coming out from Sri Lanka, India, Malaysia, Thailand, and Indonesia at this point in time. So the studies that we are monitoring itself. But going beyond that, you actually have data coming out from a lot of other sites as well, including the Philippines. So in summary, and then if I can get your help to take out your phone, give us a quick scan. So this gives you also indication to request from Sysmex any of the publications you have seen today. If you need the publications, we can share to you 100%, but I need you to make a request because of copyright compliance. We have that control to ensure that we have purchased the rights to share those papers, but only upon request by you. Hence, if you request from us, we can give it to you free of charge. Yeah. So if you don't want the papers, just drop us a note. We will be able to share that with you. Okay, today, we address 3 different aspects of hematology analyzer parameters with you. The first part being the CBCO algorithm that aims to enhance standardization, traceability for the lab, and also to basically tackle very difficult samples that takes time to check. So we looked at RED-HE as a measure of effective anemic testing or anemia testing. It's really an indicator of iron availability as a quick measure of that. It does not replace all your confirmatory tests, but it gives you quick access to look at iron availability for the patient. The essential tests for chronic diseases I would say it's inexpensive, it's cost-effective to do repeated monitoring. It's already available when you are ordering your CBC. And of course, vital for IDA measurements. So IPF as a means to look at management of dengue cases. I could go beyond that to look at MDS and others. Sorry for another time. I could also add other parameters in to build you a model for infection. That's also quite interesting because if I add in IG, immature granulocyte, I could look at the ability to, in cases of DHF, in cases of plasma leakage, can we also differentiate them better? And the data does show us yes. So it's elevated in dengue infection for IPF %. It's useful for monitoring dengue progression. It's also useful as a recovery measure as you have seen in the Indian data set. And with that, I thank you very much and happy to take any questions. Thank you.
Thank you, Mr. Sujenter, for sharing your wisdom and for that engaging speech. Your presence has made a significant difference, and we are very grateful to Sysmex for their contribution. So if you have any questions, the floor is open.
Thank you.
Thank you so much for your wonderful presentation. I have an inquiry regarding IPF. Does it mean immature platelet fraction?
Yes, it is. Thank you.
So can we estimate this fraction in the peripheral blood smear also? And can we apply the same thing?
If you are looking at, I think with trained pathologists, you will be able to estimate the number. But if you really want to test, similarly to what you get on the hematology analyzer, it is an indirect measure. If you need to test the actual number, you need to go through flow cytometry. So we will basically then tag with the right antibodies to look at early platelet fraction testing.
All right. Does it mean the giant platelet or it is different kind of platelet?
So they are precursor cells, meaning that, of course, then they will have early markers which are then elevated. So that will give you an early indication when you look at your flow cytometry data.
All right. So this is for dengue only. Can we apply this for other disease, for example, ITP or some other platelet disorder?
IGPD. Okay, that is a very interesting question. I think I like that question. Thank you, really, for the discussion. As far as I understand, there are no data set for the applications you are interested in at this point in time, but that doesn't mean that we cannot test. But IPF have been used for other aspects, including COVID-19, including for sepsis cases, including for MDS.
Thank you.
But if you are interested, do approach us. I'll be happy to take this further with you. Thank you for the question.
Your default test is impedance.
That is correct, sir.
And if you want, only you can go for the optical test.
That is correct.
So by what percentage the cost per reportable test increases if you switch over from I to O?
Okay, that really depends. So thank you for the question. I have a question regarding cost. Cost of test when we put the CBC plus diff to become CBC plus diff plus RET, which is the additional channel that you get for reticulocyte hemoglobin. Apologies, I do not have the data or the cost factor for Nepal nor India. The only reason is that it is handled specifically by our business partners. So as scientific affairs, I have no access to cost. But I do have the cost factor for the studies that I've done in Thailand. So the cost factor that, just to share with you, the cost increase for adding a RET channel when I'm doing my studies in Thailand is a fraction of about 10% or less. So I'm looking at about 8.5% increase in the total cost of the CBC.
No, I think it is more.
I'm sorry?
I think it is more, but we'll not discuss that because
Yes.
every country is different.
Every country is different.
So the other thing is that my friend from behind who asked about ITP, about other diseases, I think in ITP also you can have IPF.
Thank you very much.
So
So
when
you
you
have
give-
questions? ITP, yes, you have data.
Yes. So when you give intravenous immunoglobulin as part of treatment, so platelet does recover. So regenerating platelets are actually IPF.
Yes.
So as you said, in MDS, even in aplastic anemia also you can get rise in IPF. So in ITP also you can get.
Thank you for the comment. Yes, as rightfully pointed out, that's why I believe we can get that data set because it's probably an application that is worth gathering the evidence for. My aspect is that I do not have enough evidence to be able to justify that at this point in time. But he's definitely correct that it is possible. The results would likely to be positive. Hence, if there is that means to generate the evidence as early as possible, we definitely want to partner with any of the interested parties. Thank you for the question. Hi.
Thank you for highlighting the IPF. Basically, this IPF is so for the increased destruction. So there is a platelet in thrombocytopenia or in dengue, there's a decreased platelet. So whenever there is an increased destruction, usually IPF rises. So usually in leukemia, in case of leukemia, when the thrombocytes goes down, IPF doesn't increase. So it helps you to differentiate whether it's a infectious cause or leukemia depending upon the IPF. If IPF rises, basically something problem in the peripheral rather than the bone marrow. So it's minor. So it helps in the, one colleague asked about this IPF. So in 62 years, male with thrombocytopenia with IPF is increasing trend, then it helps in the ITP. If IPF is not increasing, suspect the leukemia or defect in the bone marrow.
And that is correct. The comment is 100% correct. So the use of IPF to do diffraction diagnosis, that is important because as a single parameter alone, just running additional, in this case, platelet F channel, the result itself allows you to do a quick differential diagnosis, which is correct. Thank you very much for sharing. Well, thank you for all the questions, and I'm happy to be here. And I'm still be here. If you have any other questions, I'm happy to connect. If you have any other interest, drop me a note, and I'll be happy to share more information with you. Thank you very much.
Thank you so much, sir. Now let's move on to our next session. We have an exciting lineup ahead, so please settle in as we delve into the scientific session 3. So ladies and gentlemen, please join me in welcoming our distinguished chairperson, Dr. Shima Verma Pradhan, who is a senior consultant pathologist at Advanced Pathology Laboratory, Birtamot. I'd also like to invite our co-chair, Dr. Pragya Gautam Ghimire, who is Associate Professor of Pathology at Nepalganj Medical College.
Good afternoon. I welcome you all to this third scientific session of the day. In this session, we have three presentations. First one is about the renal disease in Nepal, which is done by Dr. Niranjan Mainali. And this presentation, the time allotted for this is 30 minutes, followed by hemoglobinopathy diagnosis, a narrative of progress made in Nepal by Dr. Runa Jha, an overview of HLA typing and cross-matching in organ transplant, done by Dr. Rekha Manandar. The time allotted for the last two presentations is 15 minutes each. We'll take this question and answer after the end of all the three presentations. First, I'd like to invite Dr. Niranjan Mainali, who is a post-doctoral fellowship in renal and transplant pathology. He is a consultant pathologist and chairman of Pratham Pathology Lab Private Limited and is the general secretary of ACPN.
Good afternoon, everyone. Topic of my presentation is renal disease in Nepal under microscope. It's been over 2 years since I'm practicing renal pathology in Nepal, and this study is based on what I saw during this period. So let's start with the history. Renal pathology history started in 1900. And first, it was started in a post-mortem specimen, and light microscopy was used by Ellis, Furl, and Klebs. In 1950, Alwell, Bourne, Ervison, and Clark made a diagnosis of early stage of kidney disease. And by the 1960, IF and EM was available. And the first textbook of renal pathology was written by Robert Hepstinel in 1966. He died about a couple of years back, and right now the 7th edition of the book is available. Now, coming into the value of a renal biopsy, for the nephrologist, it is very, very important for the management of the patient because it alters the diagnosis in 1/4 to half of the cases, guide treatment, and change the treatment therapy in about 31 to 42% of the patient. It predicts the prognosis, and sometimes it also show the mechanism of the disease. Indication of the renal biopsy. Nephrologists, they do the biopsy when there is a acute or chronic kidney failure, when there is isolated proteinuria, nephritic syndrome, nephrotic syndrome, or isolated hematuria. Now, overall approach to the renal biopsy is very, very important because what we think is the renal pathologist diagnosis is the final, but the thing is like the renal pathology that combines the feature of light microscopy, immunofluorescence, and electron microscopy is the half part of the diagnosis. It is very quickly and easily altered by the clinical data that has been given or provided by the clinician and the lab data. So the diagnosis of the renal pathology can be altered by the simple history and the lab data. Mainly because in the kidney disease, there are very limited renal pathology responses in a disease. And same disease can have a different presentation, and the different disease can have a same presentation. So this can be quite tricky. Now coming to the pathology part, in Nepal, we do light microscopy and immunofluorescence. In light microscopy, there are different stain used, and at least 10 to 15 sections are examined to see the number of glomeruli and the pathological responses in different level. We take 2 to 3 micron section, and the common stain we use are HNE, PAS, silver, trichome, Congo, and sometime and somewhere they use MSP to see whether there's a necrosis is present or not. Approach to the light microscopy. So when we put the slide under microscope in light microscopy, there are 4 parts that we normally observe. One is glomeruli, second is tubule, interstitium, and vessel. And in a glomerular disease also the vessel are involved and the interstitium involved. In tubular damage disease also glomeruli are involved. So our primary role is also to decide which compartment is primarily affected. In immunofluorescence, we use gel, and then the section is taken about 3 to 4 micron. And different stain are used, IgG, IgA, IgM, C1q, C3, kappa, and lambda are the common one. And it depends on the protocol of the institute. Somebody use fibrinogen and albumin. C4D is used in the case of transplant biopsy, but this can be also done by IHC. In my lab, I used to do C4D by IHC. Approach to IF. In IF, we see the pattern, extent, and intensity of the glomerular staining. Along with it, we also see the deposition and the pattern of this immunoglobulin and complement in other site like tubular basement membrane, vessels, and interstitium. Electron microscopy, we'll talk about this later, hopefully when we have this in our country. Now coming to what I say before, now clinical information. So we can see one, screen pointer. Okay. So we can see one small arterioles in the center, which is hyalinized. This is one of the common findings that we see in the diabetic nephropathy. But this is also a diagnostic feature in case of calcineurin inhibitor toxicity in case of transplant patient. So in a transplant patient, if the clinician failed to give a history of diabetes mellitus, then we can easily wrongly diagnose this patient as a calcineurin inhibitor toxicity case. Second, We can see the nodular sclerosis, diabetes nephropathy class 3 in the uppermost portion. And there is a second pathology over here that is present. We can see the proliferation of endocapillary proliferation, and a lot of neutrophil are present over here. So there is a second pathology that is going on over here. So this is the most common finding that we see in case of in a post-infectious GN. So two different disease entirety is there. Now these are the four compartments that I was talking. We talk about the glomeruli. We can see the hyalinization of the arterioles. Tubules is damaged here. And we can see the interstitial nephritis over here. So all four compartments of the disease of the biopsy is involved. And normally in case of a post-infectious GN, what we expect is in immunofluorescence, IgG positive. In case of diabetes in this patient also, if any IgG is positive, we expect IgG positive. So there are two conditions where we can get a linear IgG positive in case of kidney biopsy. One is anti-GBM disease, and second, we can also get this staining pattern in diabetes mellitus. Intensity will be less, but it was neither linear nor there was a granular pattern of IgG, but there was strong positive IgA. Now the IgA nephropathy, there is one way we can diagnose the disease is nothing but the strong positivity of IgA in a direct immunofluorescence. So looking and summarizing all of this finding, there's too much of disease in one patient. So we decided to look back on the lab data. We analyzed the lab data, and then there was one finding. Probably the clinician might think that there's a less important finding, but the finding that we noticed was there was a blood culture positivity of Staph aureus. Now that completely rule out the diagnosis of IgA, even though the diagnostic criteria of IgA is nothing but a positive IgA in a immunofluorescence. Why? Because in a diabetic patient, it's clearly written and implicated that in a diabetic patient, if there is a post-infectious GN, and if it is happening because of the Staph aureus positivity, the immunofluorescence that will pop up will be IgA, not IgG. So we rule out IgA. So lab data are very, very important in a diagnosis of a kidney biopsy. Now, coming to our study, we started doing renal biopsy in our lab from POS 2078, and this is data of 27 month actually, that's wrong region, 27-month period. We received a total of 465 biopsies during this period, 452 native and 13 transplant. Age of the patient that ranged from 7 months to 75 years. So there was quite a wide range of patient. Female predominance with male to female ratio 1 to 1.71. And almost 1/4 of the patients were pediatric age group. Among the age and sex distribution, we can get the idea about the kidney pathology or kidney disease that is present in our country. If you look at the red highlighted age, 11 to 35 age group they form about 50% of the total biopsy that we receive. So a lot of young patients are having a kidney disease. Among the transplant biopsy, 13 transplant biopsy that we received, there are two cases of acute tubular intestinal nephritis, one chronic antibody rejection, one acute, actually it is hyperacute antibody rejection, one recurrence of IgA that lead to the chronic GN, one pyelonephritis, one CIN toxicity, 3 tubular injury, and 3 cases we gave the descriptive result by doing the BAMS scoring. Coming to the pediatric age group now, the most common diagnosis we encountered was that of lupus, 26 cases. Non-lupus disease post-infectious GN was the most common one, comprising 20 cases. Then there was a minimal change disease, 12, IgA nephropathy, diffuse proliferative GN. This is we have listed it as a diffuse proliferative GN, mainly because some of the cases came as a slide consultation. In some of there was no glomeruli in the IF, so we were just about to give the light microscopy finding. IgM nephropathy, FSCS, lupus-like nephritis, because we didn't have this finding of ANA positivity. ANA status was not provided to us. 2 cases of Alport syndrome, membranous nephropathy 2, other diseases, primary hyperoxaluria 1, and repeat we asked in 1 case. And when we looked at this history, 30% of pediatric biopsy presented with a steroid-resistant nephrotic syndrome were diagnosed as a IgA nephropathy. So this is a very classical case of primary hyperoxaluria. 7-month-old girl, early presentation. We can see all of the tubule are completely covered by the oxalate crystal. We can see the signing crystal in the high power field. History was very classical for the autosomal recessive disease. Both parents were related. Within the 3 generations, they got married, which was very classical for autosomal recessive disease. And then there was a history of, the mother has a history of IAP-ND and abortion. So these are the only live baby they had after maybe 3 or 4 conceived. And the patient presented with a complete shutdown of the kidney. Later, after the diagnosis was given, they took the baby from the ICU. Now coming on to the RPGN, there were 11 cases of RPGN out of this 117, where the most common cause of the was the post-infectious GN. Almost 25%, that is 5 out of 20 cases were presented as RPGN, where there was only 1 male patient and there were 4 female patients. This is a kind of striking for us while doing this data collection. There were 11 male patients, only 1 presented as RPGN, where there were 5 female patients and there were only the 4 turned out to be RPGN. So even the data is less, we can still ask question or we can do further research whether the female baby are more prone to develop develop RPGN if they had post-infectious GN. And these are the other few cases that we have. We can see the endocapillary proliferation. There is an exudation by the neutrophils in case of post-infectious GN. Chronic GN, number of cases were very less, 8, and 2 were because of the lupus. One disease that I will talk here about is the Alport syndrome. This is the biopsy finding for Alport syndrome. We can see the normal the collection of foamy cell within the interstitium. So with a positive clinical history, that's why the clinical history is very, very important to us. Both patients has had this positive clinical history. And there was the brother was also having some ear problem. The patient was having a ear problem. We saw a lot of collection of foamy cells within the interstitium. And this finding we can also explain in case of if there is a leakage of a protein in an interstitium. But in those cases, the chronicity will not be there. But here we can see the chronicity. One patient actually came with a kidney failure, complete chronic kidney failure. Another has about this fibrosis about 40 to 50%. So if we have a positive clinical history, and if we have this microscopy finding under a microscope, we should not wait for the electron microscopy, or I rather suggest not to send electron microscopy, rather go for the NGS directly. Because if it was present in our country, then yes, I would have asked to do the electron microscopy, but electron microscopy finding it takes around 40 days to come. So that bothers us, and there is like 30 more days to get a genetic report, so we can rather go to the NGS directly. These are the 2 staining pattern. This is the basement membrane pattern. This is the mesangial pattern. Adult renal biopsy. The predominant 38% was that of lupus. Non-lupus, the most common case was IgA, followed by chronic disease like hypertension, ANCA-associated GN, FSGS, chronic GN, tubular injury, diabetic nephropathy, and few others. 3 cases were those of cortical necrosis, 2 cryoglobulinemia, 1 tubular necrosis, and 1 nephrocalcinosis. We had 3 cases of cortical necrosis. All were female, all related with the pregnancy. In fact, postpartum, one had a PPH, one had IAP-ND, and one has a fetal death after 20 days. We can see the complete necrosis. There's only a couple of tubules that we can see. This is tubular necrosis that we saw in a hypertensive patient. We see all of the epithelium is lost, but the basement membrane we can see here. These are the different patterns that we see in a kidney biopsy. This is intercapillary proliferation, turning into the hobnailing pattern. Mesangial, that one is mesangial, and this one is mixed. Cryoglobulinemia, we can see some pink dot within the globules. Those are the pseudothrombi or immunoglobulins trapped in a capillary lumen. Intercapillary proliferation with some thickness of the basement membrane and chronicity. Patient had a history of a stroke. There are 2 patients. One had a history of stroke, another had a history of repeated uterine blood loss. We have compare with the pediatric age group, the chronic kidney disease was more, 50, and in percentage 14.5. Most common cause was the chronic GN. Now chronic GN we have keep here as a diagnosis because there's no other straightforward diagnosis in this case. All had a history of hypertension, but the blood vessels were not present in the biopsy, so we could not label it as a hypertensive nephropathy. Now, in the primary glomerular disease, IgA was the #1 cause. Out of the 39 IgA we had, 12 patients or 30% of the IgA were presented with a CKD. So we can easily say that a CKD is the main primary disease to call CKD. Lupus, the number were high, the percentage was low. Hypertension and the diabetes mellitus were in the higher number. So chronic kidney disease like hypertension and the diabetes mellitus are the #1 cause for the kidney failure. And in the primary glomerular disease, we can easily say it is the IgA. And the thing is like it mainly happens in the younger age group. We can see the vessel thickened, almost covered, and the chronic changes. In this area, this fibrosis area is present in one part of the artery, possibly old thrombus. Membranous nephropathy, we can see a stout opened up glomeruli present here. Simple तरिकाले हामीले भन्दाखेरिको लागि चाहिँ अन्डर द PAS10 हामीले कसरी आइडेन्टिफाई गर्न सक्छौँ यसलाई भन्दाखेरि सानो हाम्रो बच्चा 3-4 वर्षको बच्चाहरूले क्रेयनले चाहिँ जब ग्लोमराई बनाएको जस्तो मोटो मोटो when you see that those are all opened glomeruli. So if we see, then we can think about the membranous nephropathy. TMA, mucoid degeneration. In the RPGN, the most common cause was the ANCA-associated GN. 39 cases were there. And of the 21 cases, 14 presented as a ANCA. Lupus nephritis 13, anti-GBM 3, and there are a few other cases. And the one noticeable feature that we saw while analyzing the number of glomeruli involved, anti-GBM disease, they are very, very aggressive. They almost involve all of the glomeruli. Whereas ANCA, we saw about 70 to 75% involvement. Lupus, around 60. And this data is similar to the study that involves more than 100,000 glomeruli, renal biopsy. So we can say chronic TIN here, cellular crescent, fibrocellular crescent. Now coming to the lab data, this is very important because the thing is like ANA positive is the main feature why how they identify the अहिलेको क्राइटेरियामा चाहिँ ANA positive चाहिँ entry level criteria छ जसले चाहिँ SLE diagnosis लाई help गर्छ. And 163 patients were sent to our lab as a ANA positivity, but only 144 turned out to be lupus. ANA positive आउने बित्तिकै, so we have to be a bit cautious whoever we are doing the ANA IFA report. ANA positive आउने बित्तिकै nephrologists they got alert यो lupus को case हो भनेर. They don't see whether it's a 1+ or 2+. So the cases where the AN stat was given positive, 4 were the ANCA, 2 post-infectious GN, 2 IgM, in hypertension 2, FSCS, and even in diabetic, we saw ANA positivity. And in one membranous nephropathy, जुनमा चाहिँ PLA2R पनि positive थियो, in that case also ANA positive report was given. PNK positive. Now PNK is अलिकति tricky छ, किन भन्दाखेरि हामी PNK भन्दाखेरि हामी in Nepal the practice is doing the immunoblot, and the thing is like the kit comes in a combo package of MPO, PR3 and anti-GBM, and that's what we say PNK. For MPO they label it as a PNK, for CNK PR3. But these are two different entities. One is antigen, another is antibody. In the Canada, where I did my fellowship, they used to do both. And the recommended method for doing a PNK and CNK is IFA, whereas the MPO PR3 is ELISA. So of these 17 cases came out to be NCA associated GN. MPO we know has a affection for the glomerular disease out of this. And why both needed to be done? Because PNK that do not have a specificity positive for the MPO are associated with various inflammatory diseases like ulcerative colitis, sclerosing cholangitis, autoimmune hepatitis, rheumatoid arthritis, and Felty syndrome. CNK, 14 were present, and out of this only 6 were turned out to be a glomerular disease. This is sort of expected because CNK has an affinity for a vascular disease or a vasculitis rather than glomerular disease. And the case that were present also had a slightly affection for a vascular disease like hypertension, IgA nephropathy, lupus-like nephropathy. Now, why I talked about this IFA method and ELISA? Because when both this CNK, PNK or MPO PR3 is positive, it is required to diagnose NK serology positive. And when both are positive, the sensitivity is approximately 81% and specificity of approximately 96% for pauci-immune-crescentic GN with or without vasculitis. So you can imagine when we are just giving a report of either MPO or PR3 without ANCA or PNK. But if, because there's a financial status also involved, if we have to choose one test out of this, then the immunoblotting that we are doing, I prefer that thing because the finding that I observed while doing my fellowship was in about 75% of the cases, CNK was positive. Of the SLE, of the 75% of the SLE cases, CNK was positive, but none of them has a positivity for PR3. So if we have to do any one test, then PR3 we can do. And both CNK and PNK positivity is rare. Unlike मैले biopsy को report आउँदाखेरि धेरै केसको positive आइरहेको हुन्छ दुईटैको, है? But it is very, very rare, and it can happen in case of drug-induced ANCA. Negative ANCA result by no means rule out this disease, and patient who have ANCA negativity has same prognosis and should receive the same treatment as ANCA positive patient. Now, this is dangerous. Out of the 11 positive cases that were sent to me as an anti-GBM disease, only 3 were diagnosed as an anti-GBM disease. 3 were ANCA-associated GN, 1 chronic GN, even in diabetes mellitus 3. Now, a bit worrisome. कहिलेकाहीँ के हुन्छ भन्दाखेरि प्लस माइनस borderline 1+ यस्तोको रिपोर्ट दिइरहन्छ. But in diabetes mellitus, very, very clear. There was a strongly positive anti-GBM report was given. Lupus 4, 1. IgA nephropathy, 1. Now, accumulating the IgA nephropathy, total number of cases, this includes both the pediatric age group and the adult age group. We had 50 cases. This is the most common, actually, the non-lupus primary glomerular disease. And if you just focus on the age group of 17 to 25 and 26 to 35, 25 cases were there, out of which 9 turned out to be chronic GN. So this is, for the young people, this is very, very dangerous and the most common cause of CKD or kidney failure. Lupus nephritis, we had a total of 154 cases, but if you focus on the stage 4, the number of cases was also more. Almost all the patients presented in the RPGN were in the stage 4. Now, this is one interesting case that came. Normally, haम्रोमा kidney biopsy आउँदाखेरि, it comes in a tube, very tiny thread-like biopsy that comes. So our staff, they know how to handle this biopsy. But this time, we got a call that transplant biopsy आएको छ. And then I just said like, just do the billing then, what's the problem? Why are you calling me? And they said like, sir, पुरै kidney आएको छ. That was completely unexpected. To receive a transplant kidney as a transplant biopsy. And this case actually created some national headline. I think NMC was also involved. The kidney was taken out of the donor body, but a surgeon denied to put it in a recipient body, and he just closed the operation. No, I cannot transplant this case. And when you do this grossing, kidney was completely fine. There were no issues with the kidney. But when we see the section of renal artery, we can identify it by a muscle. There are multiple channels that will present within the artery. So there was a mass that was present within this artery, possibly hemangioma. And surgeon was right, it was somebody's fault, but yes, it was not surgeon's fault. And this is the dream. Someday I hope we will be able to report it in our country with this microscope also. Thank you.
Thank you, Dr. Nirajan. I want to congratulate you on your presentation. And since we are taking the questions at the end of the session, I'll request you to be available then. Thank you.
Good afternoon, everybody. Now, I would like to invite our next speaker, who is a known figure. She is none other than Dr. Runa Jha. She is the Chief Consultant Pathologist at Ministry of Health and Population. She is the President of ACPN, and she's the member of Strategic Advisory Group of Experts and WHO Headquarters. Her special interest being laboratory hematology, public health, laboratory management. I request Dr. Runa Jha to present her topic, Hemoglobinopathy Diagnosis, a Narrative of Progresses Made in Nepal. Please, Dr. Runa Jha. Thank you.
Thank you, Madam Chair, Co-Chair. Okay, so I'll be talking about hemoglobinopathy diagnosis, a narrative of progress made in Nepal. I'd like to say that this is not a technical session. It will be more of a storytelling of a journey that we have come across And of course, in 15 minutes, it is very difficult to give you a complete picture. However, it will be just a quick walkthrough of what we had before and what we have now, where we have reached now. Thank you very much. Okay, so some technical glitches always. Next slide. It's all you know. Go on to the next. Okay. So next, please. This is just my introduction. Next. Okay. So hemoglobinopathy. Backslide ma janus na hai. Hemoglobinopathies, all of you know, they are a group of genetic diseases affecting the hemoglobin, and two main groups. One is the quantitative defect in the hemoglobin, and another is the qualitative defect. So quantitative defect will be the thalassemias, and qualitative defect will be the common ones being like, for example, hemoglobin C, S, D, all those. And then there are more than 1,000 mutations are identified for hemoglobinopathies, but all of them are not significant. So only few of them actually cause significant clinical conditions and may even result in death. Next. So back Janusto. So globally, 300,000 to 400,000 babies are born with serious hemoglobin disorder every year, and up to 90% of these are in the low and middle income countries. And thalassemias in countries like Nepal also, in coming days, they are going to be one of the major public health problem, because till now our entire focus is on infectious disease, but soon with lots of effort the infectious disease are coming under control. So now these are going to be the next public health important disease. And even financially, the market size of hemoglobin, hemoglobinopathies, it is estimated to be US $5.9 billion in 2022. And by 2032, it is forecasted to be reach 14.3 billion. So that also shows how severe this disease is going to be. Next. Okay. So when we talk about hemoglobinopathy in Nepal, the first article that I could find was of Chatterjee JB in 1966 that mentions about hemoglobinopathy in Nepalese, in Gurkhas that were examined either in Singapore or in England. And like in that paper also there was mention of one case from 1958 of hemoglobinopathy detected in a pregnant female in UK. There is another paper by Adam W.H. from 1974 who collected actually 2,400 samples from Nepal, and they have reported alpha beta thalassemias and other hemoglobinopathies in Nepal. Recently, in 2016 to 20, we'll say institution-based studies have been carried out, which show a prevalence of hemoglobinopathy of 27% to 35%. But of course, these are institution-based and done on cases that are already clinically suspected. There is no population-based study available. This is just a picture of some of the papers, the paper from W.H. Adams from 1974, and another one from molecular analysis that is done in 2000, year 2000, which shows a correlation with malaria endemicity. And the lower one by paper by our own Dr. Rekha, who is the speaker next, showing how hemoglobin is found in most of the districts of Nepal. So the traditional diagnostic methods were CBC, peripheral smear, sickling test, HBH inclusions when we were residents, and like hemoglobin analysis by celluloid acetate electrophoresis and agarose gel electrophoresis. TUTH, where I did my residency, had cellulose acetate electrophoresis. That was being done there, I exactly do not know, but it was there since I think before 2000, year 2000. And agarose gel electrophoresis, paper of agarose gel electrophoresis can be found from BPKHS. So, and I didn't know about any other institution that was doing this test at that particular time. And so the CBC findings, I won't go in detail. We can see like most cases, we suspect when they have like low red cell indices, particularly in case of thalassemia trait, the indices will be very low as compared to the degree of hemoglobin. In others also, this is paper by me actually, where I have like summarized the findings. And that gave us some suspicion that, okay, this case may be the hemoglobinopathy and we should do further testing on it. And this is just the pictures from our own papers that are reported from, that are written from Nepal. So these are some of the cellulose electrophoresis, agarose gel electrophoresis, the sickling test there and up, sickle cell in a smear. Okay. So, and further this cutting of some of the snapshot of some of the papers that we have from Nepal about hemoglobinopathies. So the challenges were like CBC and other methods were also very crude method, and the electrophoresis that was used was very, very labor intensive and time consuming. Almost a whole day was passed, and still the resolution was limited, making it difficult to distinguish between that hemoglobins that migrated very closely, and also sensitivity was very less. If it was less concentration, it was difficult to detect, and some hemoglobins would be easily missed also, and even quantification was not easy. This again one findings from a paper by me. When I was working in TUTH, I did find that CBC was extremely suggestive, but yet the electrophoresis was coming negative. At that time, we do not have HPLC in Nepal, so I got a small amount of grant from TUTH research department, and with that grant, it was done on only 27 cases. I sent for HPLC to Lal's Path Lab, India at that particular time. And the finding that I want to point was, you can see for thalassemia trait, although I tested only 11 thalassemia traits, you see that 7 out of them in electrophoresis had a normal band. So only 4 was detected at electrophoresis. So you can see how serious the condition was. We are missing most of the thalassemia cases. Although other cases were being detected, particularly sickle cell, HBH, all those things like we were able to diagnose in those days. We are missing a lot of thalassemia traits, and that was proved with my further experiences also. So then we advanced further, and then came the age of HPLC and capillary zone electrophoresis. So HPLC, I have written, I think 2014, I confirmed with Samyak. Dr. Keur said that they started at 2015. So Samyak laboratory had HPLC by 2015, and in NPHL we got capillary zone electrophoresis in 2016. So this is a Facebook post by me on August 2, 2016, where I happily shared that we have installed Sebia minicap flex piercing at our laboratory, and there's an interesting story behind it. Actually, thalassemia was not talked about, other hemoglobinopathy was not talked about, but sickle cell had gained some importance. It was because it was mainly seen in the Tharu population, and there was some political interest behind it. So we were asked by Ministry of Health and Population to start to do some community-based screening for sickle cell in those particular areas. And they had given some budget to us. So my clever mind, I came up with the idea that why not do something? Of course, the politicians won't know which method is good or which method is bad. So why not utilize that budget to do something, to buy something that will test for other hemoglobinopathies as well. So that's why we came up with the idea. I searched the internet during my writing my article also. I had known about this machine. So after that, I talked with then director, and then we decided to buy this machine. And actually, Sebia didn't even have a dealer in the country. After we asked for it, they found out one dealer, and then they sold the machine to us. So at 5 sites at the same time, we bought 5 units and installed at 5 different sites, and thus started testing by capillary electrophoresis in Nepal. And that machine is still going. We are still using it. And now these are the various other equipments that are available in Nepal. Nowadays, HPLC is widely available. Many private labs have it. And it's mainly D10 that is available. In NPHL, we also have wired variant 2 and capillary 2 flex piercing that has a higher capacity. Even TUTH had got that capillary 2 later on. So this is just example why although I was trained in PGI in HPLC, my favorite, I feel more convenient with capillary electrophoresis, this capillary zonal electrophoresis, and this is how the result looks like. So it is zonal suppression based on the electrophoretic mobility, and hemoglobins are divided into 15 zones depending upon their mobility, and the reference positions are allocated. So A to F, those zones would be already there. They have control also for that, and based on which zone it has migrated, we identify the hemoglobins. So it's like it's easier and it has some advantages. Both are good methods. This is just a comparison between capillary zonal electrophoresis and HPLC. Both are good methods. Both have some pros and cons. However, I find working with capillary electrophoresis more easy. Madam Co-Chair, she has lots of experience with working with HPLC. So it's maybe it's personal preference. And what I found that is like capillary zonal electrophoresis, it is a bit quicker also, easy to handle, and since we had to give the machine to the peripheries where trained HR was not available, so that was also the reason we had to find a method that is simpler, and even and it can differentiate. Another thing is like, for example, something like hemoglobin E. Hemoglobin E is also very common in Nepal, particularly in the Rajbanshi population. However, HPLC cannot detect hemoglobin E, quantify hemoglobin E that well. So it migrates with a position HbA2. However, this can differentiate HbE as well. So I won't be going in detail about this. Okay. So what was the impact of this? So when we change technology, we always get to see some impact of it. We may not be knowing it at that particular time, but what I noted is after 2016, when NPHL started the test, and from 4 other sites also, there was a rapid increase in number of machines in private sector, particularly in the Nepalganj area and the Sudur Paschim area where the tests were being sent across the border. Those areas, they saw a lot of machines in the private sector as well. And now even many labs, they have kept it. And of course, there were more cases detected, so there was more data. People got sensitized about the disease. And it was also reflected in policies and guidelines. We can see we made a national guideline for sickle cell disease and thalassemia. So initially it was only sickle cell. Later on we started talking about other diseases as well. And researches got published, and population-based studies is also now in progress by Nepal Health Research Council. This is just a snapshot from PubMed. So I just I typed the keyword hemoglobinopathy Nepal, and what I want to focus is, after from 1970 to 2000, there were not very less cases were being published, even beyond that. But if you see, after 2016, we introduced in 2016, after 2017, there has been increased number of researches on hemoglobinopathy. So more and more, you can see just this graph itself is indicative. So there is increase in number of researches. So this is what happens when we diagnose a disease or improve our technology. So this can be reflected in this also. Role of genetic testing, of course, is very important in cases of thalassemia. It's written here, shortage of time. I am not going to talk about it. So from genetic counseling to prenatal diagnosis to carrier screening to identify the severity, everything is important. So further advancement that has happened is now we have also started molecular testing for beta thalassemia at NPHL. NGS, next generation sequencing facility, is available at NGS, and it is also available at few other institutions Dr. Nirajan mentioned in the morning. Sanger sequencing, it is available at National Academy of Science and Technology. Recently, Civil Services Hospital has also introduced Sanger sequencing. And this is one of the paper it is recently published. It's still to come. It's the molecular test for beta thalassemia at NPHL, where we tested for the common mutations. And although there are many mutations, like I thank Professor Dr. Reena Das from PGI, she gave me the sequence of primers. We got it custom made, and she also gave me the protocols, and we tested for 5, we tested for the common mutations based on previous experiences, studies, and then also from the studies in nearby countries, and we found that 5 mutations. They account for 84.3% of the beta thalassemia cases in Nepal. So there is just pictures of the agarosal electrophoresis that is done after ARMS PCR. And there is the glimpse of a molecular lab at NPHL. At NPHL, we have 5 molecular labs. So in NCD, we have 1, and the rest are for infectious disease. And what are the future directions and challenges? There are many challenges to overcome, particularly the accessibility of the test, the affordability of the test, the awareness about the test, including the molecular and the genetic test, expansion of molecular diagnosis for other mutations and other hemoglobinopathies, use of gene sequencing for diagnosis, and this molecular test, they are useless if we don't do a prenatal testing, prenatal diagnosis, so those prenatal diagnosis is still to come, neonatal screenings have to be done, and inter-institutional collaborations, very, very important. Nepal is a small country, there is no need to have big equipments in every institution. So, but we need to further collaborate with each other. So that collaboration is severely lacking. And of course, the capacity building, HR, the most important thing, that is problematic. So in conclusion, I'll say that timely diagnosis and early intervention is very, very important to improve the quality, and progresses have been made, but still there is a long way to go and lots of collaboration is needed. So these are some of the references, and I found it in the last moment and I really loved it, matches with the same theme. I still have a long way to go, but I'm already so far from where I used to be, and I'm very proud of it, and all of us should be proud of it. Thank you very much.
Thank you, Dr. Runa, for this wonderful presentation describing the journey from the CBS to the sequencing of hemoglobinopathies. The questions at the end, as already indicated. Now I would like to invite the other speaker. She is Dr. Rekha Manandar, consultant pathologist at National Public Health Laboratory, Nepal. She is the member secretary, National Technical Advisor Committee of National Bureau of Blood Transfusion Services in Nepal. She has special interest in hemoglobinopathy and transfusion medicine. Dr. Rekha Manandar, I would request you to continue with your talk, overview of HLA, typing, and cross-match in organ transplant. Thank you.
Thank you, Co-Chair, for the kind words and introduction. Before starting my presentation as such, I would like to thank the entire team of ACPN executive team members for this opportunity, and we'll be presenting on the topic overview on human leukocyte antigen typing and cross-match in organ transplant. So, as we all know that human leukocyte antigen, it's a glycoprotein complex which encodes the various genes which is situated in the short arm of human chromosome number 6, and it consists of the class 1 genes which possesses the HLA, B, and C gene, whereas class 2 which composed of HLA, DP, DQ, and DR. And in between the class 1 and class 2, there is a presence of a class 3 genes which composed of cytokine genes which comprises of tumor necrosis factor and the complement system as well, which really involves in the inflammations, but it doesn't involve in the alloimmunization processes. So regarding the HLA-related investigation, it's been applied in various disease associations. As we all know that it's been used in ankylosing spondylitis, JRA, and Ritter's syndrome as well. Even in case of celiac disease, multiple sclerosis, and narcolepsy as well. And even in the morning session, what we have seen is even it's been used in autoimmune hepatitis as well. And in pharmacogenetics, it's been used in order to see the hypersensitivity of various drugs like carbamazepine and abacavir as well. And regarding the platelet refractoriness, definitely it's an immune cause of a loss of platelets after transfusing, because it get lost because of those immunological causes. For that cases, we definitely have to transfuse the HLA masked units of platelets in those cases. So, in today's presentation as such, we will be definitely be focusing on the histocompatibility testing, that is HLA typing and HLA antibody testing, where the HLA typing, which we can definitely perform through the sequence specific priming, that where we used to have the specific primer sets As per the number of the specific primers, we can definitely use those these area as a high resolution one or the low resolution one as such. And for the high resolution one, even we can go for the sequencing based typing as well. But in our context, we have been using a sequence specific oligonucleotide. Now regarding the HLA cross matching, in our context, as a cell-based one, we have been using as a complement-dependent cytotoxicity, and another one is the solid-based assay, that is the Luminous technology, and even through the flow cytometry as well. And another part is the antibody screening panels, and if we see any antibody in a different panels as well, we can even go for a single antigen bead assay to have a individual single antigens in a class 1 and class 2 gene separately, which we haven't yet started in our context. And even the major histocomparative complex class 1 chain related antigen, that is MICA testing, which is even haven't started in our context, which is mainly used if the patient is highly sensitized. As the theme of our conference, that is, it is advances in pathology in Nepal. So I'll be focusing mainly on those tests which we have been performing at the National Public Health Laboratory, at the histocompatibility and immunopathology laboratory, and where we used to perform the complement-dependent cytotoxicity, and the other three tests which are based on the principle of the bead-based assay, that is Luminous technology, which are the donor-specific antibody, panel-reactive antibody, and the sequence-specific oligonucleotides. So starting from the HLA typing, which we have been using, is sequence-specific oligonucleotide, which procedure is based on a hybridization of leveled standard PCR product to the SSO probe, and these SSO probes as such attached to the Luminous microspheres, which provides the platform for the attachment of the DNA. And those bound applicons, which we can identify through the streptobidine phycoerythrin conjugate, which binds to the biotin which is present in the primer. And within these, the streptobidine phycoerythrin conjugate, where the phycoerythrin, it serves as a reporter dye for the presence of the bound amplicon. And these bound amplicons, sorry, it doesn't work. Sorry for the technical interference. Previous slide, please. Previous. Yeah. Next slide, please. Yeah. Thank you. Once we analyze those reactions within the Luminex technology, where we can see that the green laser that excite the phycoerythrin dye associated with a particular probe, whereas the red laser which excite the internal dyes allowing the microsphere to be classified. By this analysis, where we can see the HLA-B and HLA-DR-B1 locus through this method up to the antigen level, that is the low resolution one. And even in the report of this one, where we can see that the patient shares 3 out of 6 antigen to the donor in the class 1 and class 2 genes. And as we all know that hematopoietic stem cell transplant, it definitely depend on the HLA matching as such on the survival of the allograft. And if the HLA mismatch do occur, it affect on the survival of allograft. So in this study, where we can see that 2 studies out of 5 studies, where we can see that HLA matching is very much necessary regarding the HLA-A, B, C, and HLA-DR-B1. But other 3 individual studies, where we can see that HLA, HLA-B, and HLA-C, it's not much necessary for the survival of the allograft. And even in the another 2 studies, out of those 5 studies where we can see that HLA-DRB1, HLA mismatching, it doesn't make any difference in the survival of the allograft. So that in our context, we definitely have to have further studies in our context as well. Next slide, please. Now, previous slide, please. Now we'll move toward the another part, that is the HLA cross-matching, that is complement-dependent cytotoxicity, where we used to see the donor-specific HLA antibodies in a recipient. For that one, we used to add the recipient serum and donor lymphocyte along with the complements, but as we have been using the modified CDC cross-match, so where we used to add the DTT, that is dithiazolidinol, by which it depletes the immunoglobulin M, so it decreases the autoimmune related reactions which enhance the specificity, and in order to enhance the sensitivity as such, we used to add the ASG with the extension of the incubations. And in this reaction, if the donor specific HLA antibodies is present, it will definitely activate the complements, which leads to the lysis of the cell, and the cell itself become porous. So the eosine dye do enter the cells. So in a positive cross match, where we can see the reddish colored dead cell with the irregular margin, whereas the negative cross match is in a refractile with a regular border. Next slide, please. So the percentage of cell that it's more than 20%, then we can definitely say it's a positive one. And the main purpose of these CDC is to see the preformed antibodies in the recipient which are capable of causing a hyperacute rejection, and it's also been a part of histocompatibility workup for pre-transplant patient, but in most of the country it's been absolute, and it has been replaced by the, next slide please, been replaced by the solid phase assays, that is the Luminex cross-match, where we used to deduct the lymphocytes and made solubilize to form a donor lysates, which we used to incubate with that of class 1 and 2 bits, that is coated with the antibodies. Later on, we used to add the patient serum with the addition of ASG that is conjugated with the phycoerythrin, and is the entire test which we run in the same Luminex technology, which have the dual beam laser. Next slide, please. So which analyze the MFI, that is mean fluorescent intensity, that is the saturation of a total antigens present on the beads by the antibodies. And if the MFI value is more than 1500, then we can definitely say it's positive one. And it helps to detect the anti-HLA immunoglobulin antibodies in the patient, that is determination of patient's antibody profile against the donor. As said earlier, either the presence of or the absence of this HLA-specific antibody has a role in determining the survival of the transplant allograft. Next slide, please. So we'll move to the another part, that is panel reactive antibodies, which where we used to have panels of class 1 and class 2 bits, which is coated with the HLA antigens, and with the addition of a patient serum and as a conjugate, we used to add the ASG along with the PE. And all these reactions is also been being done in a Luminex technology. After the reaction been occur, if the PRA percentage, if it's more than 40%, then we can definitely interpret it as a positive one. Next slide, please. So PRA as such, it's a screening mechanism to determine the HLA antibody profile, determine if someone is highly immunologic risk or sensitized, and this sensitization that is expressed as a percentage of serum reactivity with the total panels. And in totality, what we can say that PRA, it estimates the likelihood of positive cross-match to the potential donors. So all those HLA reactive antibody testing, which we have been performing in order to counteract with those clinical problems. But still, those donor-specific antibodies do occur as a sensitizing rates, which we can deduct in these studies, that patients are waiting for renal, liver, and small bowel transplant. They used to have almost 30%. But in case of patients who are waiting for the heart and lung transplant, it's quite low, that is around 15 to 20%. But in case of allogenic hematopoietic stem cell transplant, the role of donor-specific anti-HLA antibodies remains under investigations. But still, if the preformed anti-donor HLA antibodies is to occur in a recipient, then it definitely do occur the hyperacute rejection or the delayed graft function, leading to the chronic rejection, and they might have to wait for a prolonged time and definitely no transplantation at all. Next slide, please. So coming to the end as such, the solid phase assay, that is the bead-based flow cytometry assay, which has a sensitivity and specificity, it's definitely high compared to the cell-based method. So it's been replaced the CDC, that complement-dependent cytotoxicity, by the solid phase assays. But if we compare the sensitivity of a class 1, even not only the sensitivity, even the specificity of the class 1, it's higher even than that of a flow cross-match. But in case of class 2, the sensitivity and specificity is little low because it won't detect the HLA DP and DQ as such. But if we compare to that of flow cytometry, it is higher in both the cases. Next slide, please. So to summarize, we can definitely say that for the initial pre-transplant compatibility testing algorithm, which definitely depends on the presence or the absence of sensitization in the recipient, experience of individual institute, that we have to perform even more studies and research as such, and even the type of transplantation, that is the various type of solid organs, and even the hematopoietic stem cell as well. And finally, the final interpretation should depend upon other supplementary tests, that is single bead antigen, which we haven't initiated, and we have to adopt that test as such in order to see the class of antibodies involved and donor history, definitely for a screening one. Thank you. At this international conference that I have put up the Himalayas as well, and would like to welcome to our beautiful country as Himalaya, as talked by our previous presenter in the morning as well. Thank you, everyone.
It's open for any discussions. No questions?
Very nice presentation, must compliment you. But my only submission is that Luminex platform and what you do, you're doing SSOP. So SSOP by Luminex has become more expensive than next generation sequencing. So now you are doing HLA typing by NGS at almost half the cost of SSOP by Luminex. So people are moving away from the Luminex platform, and Luminex is low resolution. NGS is high resolution. Here you are only 6 alleles. There you will have 10 or 12 alleles.
Yeah.
So even though it is not required for renal transplant, still because of the cost of the HLA typing, people are preferring, even for renal transplantation, HLA typing by NGS. The only place where Luminex may be used is for antibody screening and single antigen detection.
Thank you, sir, for that comment. We'll definitely look after all those matter because it's a central lab, being a national public health lab. We definitely have to think about it, and we'll move that way ahead. Thank you, sir. was waiting for another question.
Okay, I'd like to congratulate all our speakers for their excellent presentation and work, and also delivering the topics in a limited designated time. And it is indeed a matter of pride for all of us to go through those, as Dr. Runa described, a walkthrough through the developments in the field of renal diseases, in the field of hemoglobinopathies, and also in the HLA typing that Dr. Rekha has rightly described. With this, I want to conclude this session.
A heartfelt thank you to all the presenters for their presentation. Your passion for the subject was so much evident, and we feel so grateful for the opportunity to learn from you. Now, I would like to ask our chairperson, Professor Dr. Seema Verma, to hand over the token of love to our splendid speakers of the session. Thank you.
So I'd like to call upon our speakers, Dr. Nirajan sir.
Dr. Runaza, please.
Rekha Manandar ma'am. Now I'd like to call upon Dr. Mrinali Singh ma'am to hand over token of love to our chairperson, Dr. Seema Verma Pradhan ma'am, and co-chair, Dr. Pragya Gautam Kimire ma'am. Thank you, ma'am. Ladies and gentlemen, we'll now have a 10 minutes tea break to refresh ourselves. We'll resume the program at 3:40 p.m. sharp. So I'd like to request all the delegates to return back to the hall with the tea at 3:40 for our sponsor session, which is being presented by Mr. Anup Samsher Budathoki from Perfect Lab Solutions, representing Synapse Diagnostic, who are our gold sponsors for the event today.